Okay.
Just hit enter.
Here?
Yep.
Okay. Okay. Can you hear me with this? Okay. I'm hoping not to use this chair. I wasn't really feeling that well today, so I told Tom that I might have to sit down at some point. But let's hope we don't have to do that. Okay. First, you got this. Yes? Yeah. In my defense, this was a proof. And I read it again yesterday. I mean, this is relatively recent. This is 2015. And I thought, oh, gee, if I could edit this again, I'd take this part out and I'd change this. I'm sure in the real document, all the errors have been corrected. But just so you know, there's that. And then I'm going to circulate a couple of alarms. These have never been used. I got them about 2 years ago. I did a bedwetting talk, and I contacted like 8 or 10 alarm manufacturers, and I told them I'm doing the talk. Would they send me? They all sent me one except for one place. And I used to carry around like 10 alarms and put them all on. But here's a couple. It just gives you an idea of what they look like. These are beepers or buzzers. There are alarms that say, "Stop! Johnny, wake up!" Those are pretty effective. We're trying to demonstrate that empirically, but the reason I think they're more effective than just beepers is because there's been some fire alarm work done by a woman named Brooke in Australia. Try communicating with somebody in Australia. You send them an email and you go, gee, they never thought of me. And then like 13 hours later, you get a reply and you think, oh, they remember. She developed alarms that say, Johnny, wake up. Instead of just beep, 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 beep when there's a fire. They're more effective. So anyway, that's out there. That's made by Malem, M-A-L-E-M. There are 2 books that I would recommend, but I know none of you are going to do this, but I would recommend these anyway. Stop Washing the Sheets. It's like $10 on Amazon by Lane Robson. I know this guy. He's in Calgary. All he does is elimination disorders. That's all he does. And he's an older guy. So these days, he works 4 days a week and 3 weeks out of every 4. Isn't that great? And then, this is really terrific. This is 2006. Nevius and Van Gontard. I'll pass these around. It's a really good source book. These are all written by physicians. But you got to give them a break. Okay. So, good. This will permit me to see all of the slides all at once. Let's see. Take this. That's a really good question. Did you read it?
I have read it, yeah.
And do you think it's lay accessible?
Yeah.
For the most part.
I would say.
Yeah, so what that really means is that it might be a little dumbed down for you. He's in the process of revising it. And I've read part of it. And the revision, it's really written more at a residence level, which means it's really not that appropriate for parents. So it's got some really arcane stuff in there. But this is good, and this really emphasizes, for Robson, one of the big things you have to worry about is constipation in kids. If you've got any rhesus problems, you've probably got constipation problems, at least that's what Robson would say. And I think in many ways he's right. And so he talks all about that and then how to avoid constipation, and he talks about kids who sometimes they don't have time for breakfast, and then they go to school and they go through the school day and they're not really well hydrated, and then they come home from school like at 4 o'clock in the afternoon, but then they're going to go to bed at like 8 or 8:30, and in that 4-hour window catching up on all their hydration, and then they go to bed and they're taxing their bladders. And so what he does is he has them start the day with a glass of water before they go to school. So they're hydrated. And he encourages them to stay hydrated through the day. But that's not really in this talk. But anyway, so there are lots of little tidbits in that. The Von Gontard book is not for parents. I mean, it's not outlandish in any way, but it's just not for parents. Okay. This is available to you. Tom's going to send out a link or something that has this in it, correct?
You got the other article earlier, but we'll send this to the slide.
So this, I'm not very good with PowerPoint, and so this has all kinds of spacing problems because I kind of use tab and I can't get to like the margins, and I don't know how to do it. And if I'd had more time, I would have imposed on Kay. Kay's my intern. She's sitting in the corner. But so this is kind of goofy. However, if you ever need to put together a talk, sometimes you have to put together talks for residents. If you ever need to put together a bedwetting talk, this is all you need. This has everything you're ever going to want. And this Warzak and Fryman chapter, it's a better chapter than the chapter that you've got. It's much more procedurally based, and it really is much more of a how to do it with alarms. So, but you'll be able to have access to this stuff. If you send me an email, I shouldn't do this, but if you send me an email to wwarzak@unmc.edu, I can send you a PDF. Maybe I'll just send one to you, if I remember. But don't be afraid to prompt me. I have to find it, because my files are a mess. But, all right. It's true. Okay, so now when we're talking about enuresis, there's really a question of whose terminology you're going to use. If you're in the States, you're going to use DSM, and it's going to be at least twice a week for 3 consecutive months. You've got to be at least 5 years old. And it can't be because you have some kind of sickness or you're taking medication and that's messing up your system. I mean, that wouldn't qualify for the definition. In Europe, there's a group called the International Children's Continence Society. There's an International Continence Society that's all adult. And about 15 years ago, they went into International Children's Continence Society, and they have their own terminology. And this article, which is I think it's in that reference list I gave you, is the standardization of terminology of lower urinary tract and function in children and adolescents, and then a report from ICCS. These people, I think, are really going to take over the world in terms of bedwetting, toileting, elimination disorders in kids and adults too, for that matter. And so they talk about enuresis as being bedwetting only. And if you've got, instead of nocturnal enuresis and diurnal enuresis or some sort of mix, if you've got nocturnal enuresis and diurnal enuresis, they would just refer to that as incontinence. And if you just had bedwetting, they would refer to that as enuresis. And then you've got primary enuresis and secondary enuresis. Have you always had it, or have you had a period of 6 months dry, and then at the end of that 6 months something happened and now you've kind of relapsed, so to speak? Could be lots of different reasons for that. Okay, so this will give you an idea of how many times kids void during the day. If you're like 8 or more, that's a lot. And if you're less than 2 or less than, what do I have? 3. Then they consider that's a problem and you're low. So then they start looking at that stuff. And then if you're going to have incontinence, you can have it be continuous or intermittent. And what you want to look at is if it's, I guess if you're intermittent during the day, a lot of times people have overactive bladder, formerly known as bladder instability, and so you can have bladder spasms, and so you can have intense need to go out of nowhere. Whereas if it's continuous, you're not going to have that, because the the bladder instability problem, it kind of comes and goes. And sometimes it'll even express itself at night when you're asleep. And then sometimes at night you can have nocturia. Nocturia, about 30% of the kids that wet the bed at night have bladder instability as well during the day. And that's why some kids, this is getting a little ahead of the game, some kids will benefit from ditropan at night because they have some bladder instability, even though ditropan really isn't indicated for bedwetting because it's just like it's operating at a totally different level. But for some kids it may be helpful, so you ought to think about that. And then when you're evaluating kids, these are the things you have to worry about. One of the things that I especially look at, sometimes I ask about these things, and sometimes I don't ask about these things, because I don't see anybody that hasn't been evaluated by a physician first. So you need to ask these things. And one of the things that people don't do, that I would highly recommend, is you inquire as to whether or not the kids are damp during the day. Sometimes people ask, are they wet during the day? And they go, well, I mean, sometimes he's a little damp. No, he's not wet during the day. Well, but some kids will leak during the day. So they'll just be damp. It's not like they release the whole contents. It's not like they have a void. But they leak a little bit during the day. And so sometimes the evidence is, yeah, well, they're damp during the day, but they aren't soaked during the day. So you have to ask it and try and find that out. And then sometimes, people will complain about this. If they're older kids, sometimes they can report on this. Sometimes you have to ask the parent. The parent is most typically it's going to be mom, because mom's the one who comes in most of the kids. These are all things to be run down. So anyway, this is what you get. This is this the right article? Is found in this article. I hope to God it's found. Yes, this article's on your list. This is nocturnal enuresis and international evidence-based management strategy. So there's a lot of basic information here. We'll get to some of the things like how do you do alarms. I can cover that in about 2 minutes. But there's a lot of interesting information here about what enuresis is, and these guys. This is an older article. This is like 10 years old. But nevertheless, there's a lot of good stuff in there. Most of the, I shouldn't say most perhaps, but an awful lot of the good stuff is in the Journal of Urology. So anyway, what you're really talking about is overwhelming the bladder, and how does that happen? Well, you can have a polyuria problem. You could have a reduced functional bladder capacity. I mean, sometimes you see that in people. You see people that have the sensation of void with a very small capacity. And then the question is, if you wake up during the night, that's the nocturia problem. This is, like an older guy with prostate problems. And then if you don't wake up during the night, then if you void in the bed, then you've got enuresis. This is the expected bladder capacity. The ICCS people don't talk about functional bladder capacity so much anymore. They talk about expected bladder capacity. And if you just remember, age plus 2 predicts normal bladder capacity in ounces up to 12 years old. Then you'll know what to expect if you get voiding diaries from kids. I don't get voiding diaries from kids. But a lot of the physicians that I know, they'll send the kid home with a hat and say, like, avoiding diarrhea, I want to know how much you're voiding and how often during the day and what time during the day and all that kind of stuff. That would be a good practice if you had a tough case. Since I never do it, and I fix a fair number of these kids, then it doesn't have to be done. But I think as a physician, if you want to have that information, you can have that information. It gives you a more complete picture of what the child looks like. Now this is Robson. Robson, the stop washing the sheets guy. This is an invited article from the New England Journal of Medicine. So, that's, when's the last time the New England Journal asked you to write an article? It's been so long you can't even remember when. Well, yeah, me neither. So anyway, this is a great article. I have some tables here, and all the tables come from this article, right? Since you're going to have a copy of the slides, right? Not even a lunch voucher, and you want a copy of the slides. So you'll have a copy of the slides and you'll have a copy of the important reference list. And so when you see these tables, you'll know they all come from the Robson article, the New England Journal article. And it really goes through, like, how are you going to make the diagnosis in terms of history and physical for enuresis? And he goes through all the things you should ask about. And then how many times do you have to refer to a specialist? You know, as we go through this, you'll find that even though there are lots of little complications that can occur, most of the kids who wet the bed don't have complications. Most of the kids who wet the bed are everyday kids. It's about, if you get into the percentages, it's more like about 95%. So, you know, if I had a kid that was wetting the bed, I wouldn't think, gee, they need to go to pediatric GI because, you know, I don't know what to do with that. I would be thinking, well, we'll do a dipstick and we'll make sure the kid doesn't have diabetes or something like that. But otherwise, it's like, we'll just go with an intervention. But which intervention? I can't remember where I got this slide, but when you have color slides, you got to use them. And this just gives you an idea of the rate of reduction of enuresis in kids as they age, and this gives you a more a numerical table. You can see that more boys wet than girls all the way through. By the time you get to be about 15, you should be done. This would be the spontaneous remission rate, because the spontaneous remission rate in bedwetting is about 15%. You do have some people that don't remit. And I do have a slide that says there are about 0.5% of adults that have wetting problems. They probably don't have like your standard enuresis. There's probably something else going on. But nevertheless, it does point out one interesting fact, and that is there are adults out there who wet the bed. But how many of your friends do you know wet the bed? Yeah, none, because you know why? You don't go out to dinner with somebody and they say, man, I was dry last night. It was great. They don't do that. They keep it to themselves. But they are out there. And so it's kind of interesting to know that they're out there, but they're in very much decreasing numbers as they get older. So these are things you need to consider in the differential diagnosis. And I look at, you know, for me, I'm always looking at the constipation problem. But for you, you need to think about obstructions, UTIs, all these other kinds of things. But for me, I look at the constipation problem because the constipation problem is a pretty workable problem. I mean, it's so workable, you can buy some things over the counter, like Miralax, you can get over the counter. Lots of people use Miralax. And, you know, the old joke about Miracle Lax is a really pretty effective product. So there's no reason why you should have extreme constipation. But I do see kids periodically that they've been on clean-out regimens. And if parents have been told to put their kid on Miralax, and then they say, do you think he still needs it? I might think, well, they don't need it or they do need it, but you know, you need to call your physician because I just don't want to get into that. I defer all the little physician questions, even the ones that are like over-the-counter questions. I just defer all of them to you guys. You have deeper pockets, and that's, you know, you got to protect yourself. The sleep apnea problem is an interesting problem. You know, I don't know how many of you have run into this. How many people here have seen kids that wet the bed? So some of you haven't, right? But what you'll find is that there are some kids that once they have their tonsils out, problem goes away. So, and what happened was, this was kind of, you know, an adventitious finding. People found that, you know, Junior had his tonsils out and now he's dry. Isn't that interesting? And then, you know, like time went by and they said, Junior had his tonsils out. And now he's dry. And then they finally looked at this carefully. And the sleep apnea can be contributory, and the inflamed tonsils can be contributory to the apnea. And so anyway, you'll find kids that if they really have, I mean, how difficult is it for you to evaluate whether or not the kid has problems with his tonsils? It's not hard at all, right? Right? Yeah, okay. So that's something you should look at. The kid comes in, he's wetting the bed, I just take a look at that, you know, for sure. And then you've got these dependent measures. How many nights do they wet? How many times do they wet at night? Some kids wet more than one time. What's the size of the wet spot? what's the latency from the time the alarm goes off until the time the kid gets up, and then how much do they void in the toilet after awakening? That's a pretty interesting measure, because what you'll find if you put kids on alarms, you'll find that sometimes you get them up and take them to void, and they won't void at all because they're already finished. It's like, thanks for waking me up, but like, I'm done. But so you take them and you see how much do they void. And one of the things you can do, even if you're not measuring it, you can hear it. And one of the things I've thought of, this is something for you to do. I'm not talking to you, Tom. I'm talking to Kay. This is something you can do. Can you use a stopwatch as a functional measure of voiding volume using an individual as their own control? And then you would find out that they're voiding longer and longer, or if you were really measuring it, they're voiding more and more. And as they're voiding more and more in the toilet, that tells you that they're waking up earlier and earlier in the cycle of voiding in the bed. And so then that tells you that your alarm is working. Your alarm might not work right away. I mean, I ran a study at UNMC on this. This is a long time ago, but we ran the study for 12 weeks. And DDAVP, which is very common in Europe, it's not called DDAVP. Well, I mean, it would be, I guess, but I think the trade name is Minorin in Europe. But because they have a lot of nationalized medicine in Europe, they have like kind of standard protocols for some of these things. And all the kids that are bedwetting, they go on DDAVP first. But they usually, when I was running the studies, again, some time ago, they only put them on it for a month. A month's not long enough. I mean, they put them on alarms first before they put them on medication. And they put them on for a month's not long enough. So if you put somebody on it for a month and they go, well, it's still not working, I would say, we need to do this for 12 weeks. And at the end of 12 weeks, if you still have a number of accidents, then I would say, well, maybe we should add a medication. DDAVP is fairly effective. DDAVP, one of the things about DDAVP is that, it's a little bit like taking Ritalin. It's here today, gone tomorrow. And you can evaluate whether it's going to work pretty quickly. So I'll run into some parents and they'll say, well, he's been, we're running like a 6-week trial of DDAVP, and I'm thinking you should be running like a 3-night trial of DDAVP. Because if it's going to work, it's going to work. But you can always double up on the dose. I mean, I won't tell you how to dose DDAVP. But DDAVP is pretty safe, except you can't be drinking a lot and taking DDAVP. Because it has to do with concentrating your urine and the osmolality of it. And so what can sometimes happen is that if you tell Johnny, well, we're going to take your medication at 7 o'clock, and then at 6:50, Johnny loads up on fluids because he knows, well, I can't take them after 7, but I can take them before 7, because that's the way kids think. I mean, kids think really nutty things. Just listen to Keith Allen's talk about some of the things that kids think. So you have to control access to fluids for kids that are on DDAVP, whereas if you've got kids on imipramine, which people don't prescribe that much anymore for medication, or for medication for enuresis, but if you prescribe imipramine, then you have to keep the kid away from the imipramine, but not from the fluids. If you prescribe DDAVP and they get into the DDAVP, they're probably not going to have too much of trouble with that, but you've got to control water coming out of the faucet, in a sense. Okay, I've got lots of slides, and I'm not going to go through all these slides, and I'm not going to just read the slides to you, so you can read through some of these slides. Comorbidity of enuresis with ADHD is about 30%. So if you have kids coming in for enuresis, it's always worth asking, do they have ADHD as well? Are they taking anything for it or not? I mean, you don't have to take medication for ADHD. A lot of people do, but you don't have to. Psychiatric history. I wouldn't worry about the psychiatric history for being the etiological factor in enuresis. But you do get this. People find out you're a bedwetter, and it's a problem. And so kids at school can get teased about it. So kids, of course, don't talk about it at school. Again, they don't want people to know. But one of the things you can do with kids, and you should do with kids, is you should tell them that they're not the only one in class that has this. that there are other kids, probably in their homeroom classroom, there are probably other kids that wet the bed, and they just don't know it. And then if you interview the parents, I've had this happen a number of times, and you might interview mom and dad, and dad will go, yeah, I wet the bed as a child. Mom will go, really? So, some of these some of these things, people keep them to themselves. Of all the things you can keep to yourself, I guess I understand keeping bedwetting to myself. But nevertheless, like we've been married for 15 years and now you're just telling me? No, well, it works that way. People are embarrassed. We did this. Yeah, this is probably worth talking about. Enuresis probably causes more problems as a function of having it in terms of people reacting to it than having kids have some sort of bad experience and then developing enuresis. I wouldn't worry about that. You will sometimes have people that, and this is probably much more common with a secondary enuresis. The kids come in and the complaint is a secondary enuresis, which means they've had a period of being dry for at least 6 months. And then people always go, well, he must have been abused by the janitor. So let's interview everybody at school. I mean, the sexual abuse issue often comes up. I think it's not an issue that can be ignored. You can't just say, well, don't bother with that because that's a long shot. It's like, I know that's a long shot. So we ought to inquire about health and safety and make sure those bases are covered. But that typically is not what you have. That's the good old days. Sometimes when we're talking about just toilet training kids, this really isn't about toilet training, because it's about enuresis. But one of the last things I do if I don't have success toilet training kids is I'll pants them, like that kid. That kid might be a little young, actually, but we'd probably start around 2.5 or thereabouts. But if you pants kids, of course, they might pee on the floor. But a lot of times it's like they won't pee on the floor. So anyway, that's something you can think about. Okay, this is the primary secondary enuresis issue. We've talked about that before. Then these are issues related to secondary enuresis. Again, this is the work of Lane Rapson. Most of your bedwetting cases are the uncomplicated cases. That is, there's nothing else going on with these kids. They just wet the bed. But how come they experience polyuria? You can ask that. And do they really have a smaller expected bladder capacity than other kids? You could ask that. But they usually don't have some sort of wacky medical condition that's contributing to enuresis. So these are some of the things that can happen associated with uncomplicated primary bedwetting. The small capacity, they fail to wake up. The polyuria problem, and then you've got some of these other issues. But I think what you're really talking about is having the bladder become overwhelmed, and so the kid voids. And I have a study in here someplace, and the study is, it's a citation for a study. And there was a study it was probably done about 10, maybe 15 years ago. It was published in the Journal of Urology. And they took everyday kids who were dry, and they gave them a large volume of fluids before they went to bed. And they were able to provoke wetting episodes in about a third of them. So it's conceivable. So right before Johnny goes to bed, don't give him a big gulp of Mountain Dew. I wouldn't do that. But I wouldn't really limit fluids too much on kids before they go to bed, especially in a place like Omaha. Omaha, it gets really hot during the summer here. And Omaha is a town where they have a lot of organized sports activities, soccer, baseball, that kind of stuff. They play after school or in the evening. And so you have a lot of kids that get dehydrated because it gets hot here. I mean, I'm sure most of you have been here through a summer, but you can have 90-degree weather here. I mean, that's nothing unusual to have 90-degree, high 80s. Kids are running around, and then they come home, and you feed them, and you say, well, now you're going to go to bed. But we don't want to give you any fluids because you're going to wet the bed. I wouldn't do that at all. Excessive intake of fluid, although if you want to, experimentally, you can probably provoke wetting episodes in a certain proportion of the sample. But for the run-of-the-mill kid, if he wants to go to bed and he wants to have a small drink of water before he goes to bed, I'd say go ahead and do it. Because we've got lots of other things going on besides worrying about how much they drink before they go to bed. This gives you an idea of the relationship, the familial relationship between occurrence of bedwetting and whether you've got one parent or both parents being anoretic. You can see it's a factor. These are the spontaneous remission rates for kids at different ages. You can see what we don't know and what we'll never know is if you've got a kid, let's say your kid is 8 years old, and a lot of people that start working with bedwetters, they don't even start until kids are about 7. And before 7, they don't really worry about it. So you want to know how many times they're wetting a week. If they're wetting once a week, I probably wouldn't put them on an intervention. I'd be thinking, well, did you used to wet 6 days a week, and then you wet 5 days a week, and then you wet 3 days a week, and now you're wetting 1 night a week? Unless the kid has a medical problem, it's probably going to remit. But what you don't know is, if I'm wetting 7 days a week now, what's the probability that I'll be dry next week? I mean next year. And then if I'm wetting 6 days a week or 3 times a week, what's the probability that I'll be dry next year? Nobody can answer that question because nobody's ever done that study. It's one of those studies that, when you think about it, you get 50 little boys and 50 little girls, and they're, like 5 years old, and they wet 7 days a week. And then you look and see what happens to them a year from now. And now we'll get another 50 and 50, and they're wetting 6 days a week. And now we'll get another 50 and 50. And then you go to NIH and you say, I'd like to do a $10 million study. And they say, what for? And you say, I just want to find out, what's the remission rate on kids who wet the bed? And they're thinking, we're trying to cure cancer here, and you're worried about bedwetting. So, it's hard to fund studies like that. So we don't know, what the odds of you being dry next year are, given how much you wet now. But it's safe to assume that the kids who are wetting a lot, 5, 6, 7 nights a week now, they could easily still be wetting next year. So let's do something about it. This keeps kids from going on overnights, which is why God invented sleeping bags. Sleeping bags for kids that go on overnights. I'm just more comfortable in my sleeping bag. You can put an extra set of clothes in there. You can take off wet clothes and put them in a sleeping bag. And then kids can go on campouts. They can go to a friend's house. There are lots of problems with wetting in the bed, and it keeps kids from doing a fair number of things. Something else I wanted to mention, this is the last I think, show and tell. This article's on your list, and we went through the familial stuff and how many. The point of this article is, at what age, how many kids are wetting at age 2, at age 3, at age 4, at age 5? And this guy did like a sample of 1,200 kids that walked through his office. He's at the University of Michigan. He's still there as far as I know. And this is Bloom, OOM, and I think that's a really good article. It's one of the articles that I'm sharing with you. So that, again, if you want to get those statistics probably haven't changed much over the years. So these are all things that can contribute to wetting. This would be during the day. These giggle incontinence. Are you familiar with giggle incontinence? Giggle incontinence is like people giggle literally and they lose bladder control. And stress incontinence can be like, you could be an older kid and you could be going up for a rebound or something and then come down and put stress on the bladder, on the sphincter. So these are all things to think about. Post-void dribbling, well, you really shouldn't do that. And when you finish voiding, you should be finished. You've got to worry about, this is a problem that sometimes you'll see in little girls because they'll have a little bit of vaginal pooling and then they stand up and now their panties are damp. So you got to make sure it's not just like a hygiene problem. And that's also true if you're dealing with encopresis. When you're dealing with encopresis, first let's make sure it's not a hygiene problem. And if it's not a hygiene problem, we can go further. Because, sometimes kids are, they're 5 and they say, okay, we'll get cleaned up and we got to go. Well, kids at 5 are still in the, Mom, I'm done. And Mom goes in and, I don't know. Does anybody here have kids? Tom, you have kids.
I do.
How are they doing with these things?
I have grandchildren. Let's see.
Okay, so I think that we have data that suggests that some kids, this was really hot for a while. We have data that suggests that some of the kids who wet the bed, they have low levels of ADH, antidiuretic hormone. Antidiuretic hormone is something that has a circadian rhythm to it. And so the normal kids in the study, a small study, but it's done quite a while ago by Norgard, he's still out there. The normal kids have a rise in ADH throughout the night. ADH is something that allows you to concentrate your urine. And the kids who are anuretics, they don't have that circadian rise. And so this is where DDAVP comes from. I mean, they first discovered this when they were working with diabetes insipidus, and they found out they could give this stuff to people with diabetes insipidus, and then they had fewer, smaller voids. Then they thought, So they extended it to kids that are bedwetters. What we know now is that, what we know now is that there are some kids that wet the bed that have lower levels of ADH, but that's not all the kids. So it's one of those things, as you investigate it more and more, you can parse the sample into smaller and smaller pieces because you start asking more and more questions and finding out more and more information, and so you find out not all bedwetters are alike, but some of them have some problems and some have other problems, and some of them have the DDAVP problem, which is just the vasopressin problem. It's an artificial vasopressin. This is what a lot of people want. It's almost regardless of the problem that kids present with. What they're after is this. So if you're going through the pharmacological interventions, DDAVP is probably the most common. The ditropan and the detrol are really for overactive bladders, bladder spasms, stuff like that. I think that there is a place for imipramine. I mean, some kids have ADHD and they'll use imipramine with kids that have ADHD, or some kids. But you use it in a much lower dose than you would use if you were treating depression, for example. DDAVP is really the pharmacological intervention of choice. And here, Lane Robson has laid out very nicely the difference between imipramine and other tricyclics, the anticholinergics, and then in particular he goes through desmopressin. Recommendations for the use of alarm therapy. Alarm therapy is the first line of therapy, and alarm therapy is the most effective therapy. It's not the easiest to do. I mean, it can be difficult for parents, and so you have to kind of prepare parents. Like, this could take a while. And this would be true for all of these interventions. If you try them and you're not successful, then you could wait a year or two and try them again to see, if the kid hadn't resolved, try them again, because they tend to be more effective as kids get to be older. And what you have to do, are we here yet? Well, we'll get into that. So restricting fluid intake, I wouldn't bother doing that. There's not evidence to support that. Very common, that's like the common wisdom, but I wouldn't do it. Caffeine, we did a study particularly to look at the effects of caffeine and see whether or not caffeine induced anuretic episodes in kids. And we published a paper on this about maybe 5 years ago now in Journal of Pediatrics. And we found this is kind of interesting. It was just a survey. It wasn't a big deal study. And we found out that caffeine really didn't affect bedwetting at night. But again, if you're going to have the big gulp of Mountain Dew, it's going to affect bedwetting. But in general, we didn't find that. But what we found was caffeine affected how well the kids slept at night. And so this provoked dozens, 3 dozen, 4 dozen interviews. I was getting calls from Time Magazine and Newsweek and the New York Times and the Washington Post and Discovery Channel, and I did something for like Voice of America that they beamed out over to Africa and all this. But you're looking skeptical. And in 2011, I made the Drudge Report. Are people familiar with the Drudge Report? Well, it's a right-wing political hack job on anybody that they don't approve of. And it's run by a guy named Matt Drudge. And a friend called and said, "You made the Drudge Report." But I made, there's another one out there. I can't remember what the name of the site is. But every year, they convey no-duh awards. The top 10 no-duh awards, I think for scientific research. And in 2011, I made the list so you're telling us that caffeine is disruptive to sleep for kids. So the no-duh award for 2011 goes to, but this was what people wanted. They really wanted this. And we had revised the article a number of times, and the sleep piece, which just fell out of the survey, is what people were really interested in. And they weren't very much interested in, oh yeah, it doesn't affect bedwetting very much? Yeah, okay, fine. But let's talk about the sleep thing. And I'm thinking, there are all the people that are writing these articles, they know that when they need to stay up at night, they're consuming caffeine, at any rate. Bladder retention training, I wouldn't do this. Some people do. What you do is you try and find out what's their functional capacity right now, and then you say, well, the next time you have to go, try and hold it and see, and then you can measure again and see if you can get larger and larger capacity. There is some evidence that this is effective, but it's not solid evidence that it's effective. But I used to, for about 10 years, I consulted for National Kidney Foundation, which was all nephrology people and urologists, and there were a couple of pediatricians. And Robson was on that. Well, some of the guys on these articles, Bloom was on that. They would never do bladder retention training. They thought they were worried about reflux into the kidney, and they just thought, you're asking for trouble here, and you don't have to do it in order to be successful. So none of them did it clinically, and so if they're all saying we don't do it, then I'm not doing it. So I don't recommend bladder retention training, but you'll hear that out there. But I think it's a little bit on the risky side. Schedule awakenings, not helpful. Some of these studies are older studies, but there's nothing new out there. So sometimes you have a finding in a study, and it's like Grey's Anatomy, the book. How many people have seen Grey's Anatomy, the book? Right? Yeah, okay, so that's probably 250 years old or something like that. So when's the last time somebody checked out Grey's Anatomy to see if we're still made the same way now as we were made then? Well, nobody would do that. So sometimes you have studies, and it's like, we know certain things, and we just know them to be true. Because they've been looked at, and so this has been looked at. Scheduled awakenings helps keep kids dry. It doesn't teach them how to be dry. Some people think the kids that wet the bed, they have a disturbance of sleep. You will find that some kids are, I see a lot of kids and their parents go, oh no, he's a really deep sleeper. But there are lots of really deep sleepers out there that are dry. As a matter of fact, most of them are dry. So, and when you really look at the sleep phases, you'll find that you get a distribution of wetting episodes throughout phases. So I think that's probably not an issue. There are some data to suggest that it takes a stronger stimulus to wake up kids who are bedwetters, an auditory stimulus. That's not the same as bladder cues, but nevertheless. So that's out there, but I don't worry about that too much. Overlearning, when your kid gets to be dry, let's say they're dry for 2 weeks, then what you want to do is give them, what was that? Then what you want to do is give them a challenge. So give them 8 ounces before they go to bed at night, and then see if they can be dry again. Sometimes they'll wet, but briefly, like a matter of days kind of thing, and then they get back to being dry. So there are data that support that. Urotherapy, this is something you would see in Europe. If you looked it up, it would be all in the Scandinavian journals. So, urotherapy is something that people do. So it is something that people are. They are urotherapists. And they get involved in the demystification piece, which is really important. Other kids have it. You're not the only one. Uncle George had that, all that kind of stuff. And they they really get into timed voids during the day, and they have fluid loading, and it's a whole way of working with kids, and they try and avoid medication, and they avoid alarms. They've got posture issues, the constipation issues. The posture issues, that posture is not that important when you're talking about bedwetting, obviously. But for kids that you're working on for toilet training, or for kids that have constipation and caprices problems, you want to support their feet when they sit on the toilet. So are you people familiar with squatty potty? Who's familiar with squatty potty? If you're not familiar with squatty potty, you ought to just Google it. I mean, it supports your feet and it changes your posture, so it facilitates elimination. Anyway, that's out there. Okay, and this is just a calendar. And you can record, were you dry, sleep through the night? Were you dry because you got up to void? Or were you wet during the night? So I would read this. I'm going to talk through this. Whoa. But what this really does, and this will be available to you, but what this really does, it says when you put the alarm on the kid, the alarms are of different types. Some alarms, they attach to the buzzer part. You have the alarm clip. It's like you put your underwear or whatever the heck you wear to bed through the clip, and it snaps on. It's like taking a 9-volt battery and just folding it over on itself. And that always goes in the crotch of the undergarment. And then, it's attached to an alarm, which you've seen these, and they all have batteries. And then when the child wets, then the undergarment becomes wet, and so then it makes a connection. The alarm goes off. So sometimes the question is, well, where is the alarm? Sometimes the alarm is on your arm. Sometimes it's on your collar. I use one from Star Child Labs. I'm going to start using a different one. I'm going to start using the Malum. There's a place you can go, I think it's in the slide set someplace, called bedwettingstore.com. It's got all kinds of continence products in there. And so even if you had, if you were seeing adult patients and you had continence problems, you wanted some products, I'd go to bedwettingstore.com. They've got everything you need. Anyway, if you have the alarm on your arm, on your wrist, you can put your wrist out here, under a pillow, off the side of the bed. The one I like currently snaps here to the collar, so you can't get away from it. So when it goes off and it's like right here. And then what you want to do, you'll find that a lot of kids won't wake up to the alarm. They'll sleep right through it. And parents go, well, like he doesn't wake up. I use he most of the time because you see more guys than you see girls. But it's okay that they don't wake up to the alarm. Because what you want to look at is what's the size of the wet spot? And is that decreasing in size? I mean, some studies will even measure the wet spot. If otherwise, you can have parents that will say, yeah, it's smaller this week than it was last week. I mean, some things you don't have to actually precisely measure. But, and then, are they voiding in the toilet now after the alarm goes off, whereas they weren't before? And then you want to have the kid disconnect the alarm, not have the parent disconnect the alarm. So if the kid doesn't wake up to the alarm, but the parents wake up, I've even known kids that have had baby monitors in the bedroom of the child who wets, and then have the receiver in the parent's bedroom so they could hear the alarm go off. But I'll tell you, most of these alarms, not a problem for the parents to hear the alarm go off, even if the kids sleep right through it. So the parent comes in, and then what you want to do, if you're the parent, you want to wake the kid up. Don't you disconnect it and then wake the kid up. You want the kid to wake up and have the kid disconnected. It just has to do with the pairing of stimuli. You want the kid to wake up and have that alarm going off, not have you terminate the alarm because you find it aversive. Well, yeah, okay, fine. It's aversive, but nevertheless, the procedure is have the kid do it. Don't have the parent do it. Then, take the child to the toilet, have them void, and then you might want to have the child assist in cleanup. They can always do part of that later. Sometimes, I have some parents that they make the bed twice. So like it goes without saying that you've got a plastic sheet on a mattress. Either that or you've got a closet full of mattresses. You put a plastic sheet on, you make the bed, then you put another sheet over that, plastic sheet over that, and then you make the bed again. So then, if the kid wets, you can, if it's a small spot, I mean, you can put a towel on it. I mean, how many people do that? Lots. But if it's big, you can just take off all the old stuff and, put it in a hamper someplace, and now you've got another clean set. Sometimes what happens is that kids will wet the bed, and then they get into bed with mom and dad. So there's a not so hidden contingency there for wetting the bed. If you wet the bed, you get to sleep with mom and dad. Lots of kids like that. So you've got to make sure that that's not interfering with your child's bedtime sleep hygiene, sleep through the night, becoming dry, that there's a little motivation in there for them to be wet. Anyway, then they rehook up the alarm and you go back to bed, and then you've got this calendar you can fill out. I'm going to keep track. And then what I do for a lot of the kids is I'll put in some motivational contingencies for them. But I don't have motivational contingencies for being dry, because I think bedwetting, you really run into it being a biobehavioral problem. It's interesting when you think of it as a learned behavior, but what are they learning when you put them on an alarm, and now after being on the alarm, now they're dry? And actually what you'll find is that when you put them on the alarm, they have studies that demonstrate that putting them on the alarm increases functional bladder capacity. How does that happen? I don't know. I don't know how that happens. Anyway, they're learning something, and so we refer to enuresis as a biobehavioral problem because there's a big bio component. If there's a bio component, although Dr. Raylan, he does a lot of biofeedback. Biofeedback training is one of the things he does. So you can change this by these components, by giving feedback to people. And there are some people who even think of the enuresis alarm as a biofeedback device because it's giving you feedback that you weren't getting previously. But nevertheless, there are treatment packages. There's dry bed training, very intense. You can look this up. Azrin died about 2 years ago. Brilliant guy, kitchen sink approach. Azrin and Fox, Foxx, they wrote a book called, well, this is really not for bedwetting, but they wrote a book for toilet training kids called Toilet Training in Less Than a Day. Are you familiar with this book? Well, it's way too complicated for parents, even though it's written for parents. But the idea was, and the idea with dry bed training, is that it's a multi-component treatment. And so they never took apart the treatments to see which component really is effective. So for dry bed training, you'd have the kid lie in the bed. You'd turn the alarm on. You'd have the kid get out of bed, run to the bathroom, void in the toilet, get back in bed, put on the alarm, head down. 30 seconds later, alarm goes off, get the kid up. I mean, you run through these trials. It's very intense. Parents can't stand it. But anyway, there's evidence that it works, but which parts of it work? You still have an alarm in there. So, this is full spectrum training, a little bit more parent friendly. How to use retention control training, I don't do that, but they use the bell and pad, they use overlearning. They don't use multiple trials at night, sometimes referred to as overcorrection. And then there are treatments that combine DDAVP and imipramine, and behavioral interventions, which is just the alarm. The alarm is very behavioral. We could go into all the little details, but there's no reason to do that. But in the end, as I started to say before, the DDAVP, it's in today and gone tomorrow, just like your ADHD meds. But people don't really acquire being dry. As long as they've got a DDAVP problem, and if you're dealing with kids that are short on vasopressin, they don't have the nocturnal surge at night, then DDAVP is helpful. but it's stop giving them DDAVP, and then what happens? So what might be happening when they stop giving DDAVP, sometimes you'll find that, well, now you've been doing it for 6 months or a year, and now you're aging into the next category of, people age out of bedwetting. The problem you have as a practitioner is when they bring in the kid and the kid's wetting the bed, you don't know if it's their year to remit. Are they going to remit this year or not? You don't know. And that's why you get into the kind of study. Wouldn't it be nice to know, given the age of the kid and how many nights a week they wet, what are the odds that they're going to remit next year? But we don't know that. This is merely, I'm not going to go through this slide. This is merely to demonstrate that this is an algorithm for evaluating bedwetting. So even though a lot of times, maybe most times, you have a very uncomplicated case, you got primary aneurysm, it's starting to resolve, but they want some help kind of moving it along. There are all kinds of little things you need to worry about. And if you have things you need to worry about, you really need to get an expert. And Johnny's an expert in fertilizer, so I just put that out there for your amusement. I wouldn't do this. I wouldn't have kids in timeout or some other punitive procedure because they're wetting the bed. I mean, people do that. If that was going to work, we wouldn't be having this conversation. So, don't bawl a kid out for being wet. Don't make the kid feel guilty for being wet. Don't punish him for being wet. Take away his bike for being wet. That's just totally pointless. I would not do that. Okay. That's it. Any questions? I went 1 minute longer than Dr. Allen. Right. Yeah.
There, psychological therapy, is that for?
Like conversational therapy, like how you do. I wouldn't do that. Anybody else?
How many kids do you see like in your time?
Not a lot. But I've been seeing not a lot for 35 years. Yeah, I don't know why we don't see more. I see more ankle product kids, poopers, constipation kids. We see a lot of those kids.
How many psychologists in the community do this kind of work?
A handful. They would probably do this at Children's. They would certainly do this at Emma Monroe Meyer Institute. There are some others, but
So where would they make referrals?
well, they can call Meyer. I mean, I think Meyer has a pretty good faculty.
Yeah, I copy with Holly and all the ones on the clinic here.
Yeah, and also Meyer has a lot of satellite clinics.
Do they take referrals from people outside their clinic?
Some of them do. So I don't know how many satellite clinics we have now. But children's, a lot of these are children's, and they're children's Creighton clinics. They're all over town. Even the outpatient pediatric clinic that's in the hospital is a children's clinic. It's even logoed.
But Mike Vance and all those stuff there.
Yeah, Mike, they'd be fine. Okay. But they wouldn't be as good as. But otherwise, they'd be fine.
Mike's is the same thing.
Any other questions? Okay, then we're done. Thank you. Okay. So I've got this. And I've got this.
I'll send the link has to get uploaded.
Okay.
So we'll have Dr. Brooke email you with the
Okay, great. Is this my
Thank you.
$100 gift certificate to some fancy restaurant downtown?
No, that will be in the link with Dr. Brooke.
Okay. All right, thanks. Whoops, we better undo this.
I'll come around.